Okay, moving on to history of present illness. Upon inquiry, she tells you that she was in a good state of health 3 days prior. Then, 2 days ago, she started experiencing pain in abdomen. The pain in abdomen was sudden in onset. It started around 6 a.m. that day, initially around the umbilicus, but has become more localized on the right lower abdomen at the moment. She describes the character to be piercing and the pain is continuous. No any relieving or aggravating factors were noted. And the pain did not have any particular relation to the food or any timing. And the pain was severe enough to disrupt her regular activities.
Continue.
Okay, next slide. अलिकति फास्ट भयो भने do let me know है मलाई अलिकति फास्ट बोल्यो भने चाहिँ. Okay, moving on. She also complains of rise in her body temperature since the last day. This is sudden in onset. She had documented the temperature to be around 101 degree Fahrenheit, but she denies any chills and vigors. No any particular relation with timing was noted. Her temperature decreased up to 99 degree Fahrenheit upon taking paracetamol from local shop, but it again came back later. Next, please. Okay, these symptoms were accompanied by vomiting. She total had 3 to 4 episodes of non-projectile vomiting, which were initially containing undigested food particles, but later become watery. About 1 cupful each time. The vomiting was non-bilious, non-blood stained, and non-foul smelling. Upon further questioning, she denies any trauma to the abdomen, any change in her bowel movements, or any blood in her stool. Okay, next. Okay, on systemic review, she denies any cough, shortness of breath, chest pain, and palpitations. On nervous system review, she denies any loss of consciousness, abnormal body movement, any rashes. She does not have any burning micturition or alteration in her bladder habit, and she is currently on her mid-cycle of her menses. Her menses are regular with normal menstrual flow. Okay, next, please. Moving on to past history. She denies any similar illness in the past. She's a non-diabetic, non-hypertensive, no any previous history of asthma or any thyroid disease. She hasn't had any previous surgeries. So this is her past history. Okay, let's move on. Moving on to her personal history, she denies any alcohol consumption and smoking. There is no any past history of blood transfusion, tattooing, or piercing. She says that she consumes mixed diet, both veg and non-veg, and she is sexually active. Her bowel and bladder habits have been normal previously. So moving on to family history.
एउटा सानो रिक्वेस्ट आएको छ अलि स्लोली प्रेजेन्ट गर्न भन्नुभएको छ पार्टिसिपेन्ट्सहरुले.
Okay, म सुरुमै सोधेको थिएँ नि if I am presenting अलिकति फास्टली त्यो भन भनेर है. Okay, I'll try to lower my speed.
Okay.
Okay, moving on to family history. She says that her sister also had similar complaints in the past, and her sister underwent surgical management, but you could not obtain the details from her. Otherwise, no any significant surgical or medical history in the family was obtained from the patient. So this is our family history. Okay, this diagram shows our family tree or pedigree chart. The highlighted arrow is our patient, who is Mrs. Thapa, a 28-year-old female. Okay, she presented with pain abdomen for 2 days, fever for 1 day, and multiple episodes of vomiting for 1 day. Okay, next slide, please. Moving on to socioeconomic history. According to the Kuppuswamy grading, which is a grading used to determine the socioeconomic status of a person or a family, our patient belongs to upper middle class family. She lives in a 2-storied house with separate bathroom and kitchen. And they use normal cooking gas for cooking food, and they use filtered water for drinking. Next slide, please. Okay. drug and allergy history. This is a very important part of history. She, as I've already mentioned, that she had taken paracetamol for her fever, which decreased it to 99 degree Fahrenheit, but the fever again rose back. And she is not on any other medications currently. And she says that she does not know if she is allergic to any other medications or any other substance till now. So okay, this concludes the history part of our discussion. I'd like to ask Dr. Rajesh, sir.
Aryan,
Yes,
now
sir.
I'd like to ask you a few things.
Okay, sir. Sure.
With your history,
Yes,
what do you
sir.
think the diagnosis is?
So with my history, I have quite a few number of differential diagnosis in my mind right now.
Okay.
But the overall case seems to be
No, with the history only, not overall, just the history.
So with
you go back to the first slide. Yes, here. She presented with pain, abdomen, fever, and vomiting.
Yes, sir.
Okay. And the next slide. Next slide. Okay. This is your history of presenting illness. On
Yes,
presenting illness, whatever you have said.
Yes, sir.
Just with chief complaint and presenting illness, what are your differential diagnoses?
So just with the complaints that the patient presented and our history of presenting illness, I think this case is related to acute abdomen, sir.
Acute abdomen, yes, very good. So what happens is most of the time, almost 80 to 90% of the time, the diagnoses are made after history of present illness, because the rest of the history are relevant but not as relevant as HOPI and chief complaint. So you have to be very careful while checking the history of present illnesses, and every point is important here. Okay, you said that it is sudden in onset. So
Yes, sir.
how does it help in your diagnosis? Sudden, insidious?
So
Okay.
when the pain abdomen is sudden in onset, we can think that the pathology that the patient is suffering from is acute in onset, or it is of recent origin. Whereas if the patient was pain was gradual, it means that she had been experiencing this from a long time and it has bothered her today. The pain has increased such that she has presented to the ER at such a time of time.
So it is sudden in onset means it's a sort of acute abdomen. Can you define what is acute abdomen?
So acute abdomen is any sort of pathology in abdomen that the patient is forced to come into the emergency department because it is not tolerable, or that the patient could not manage herself or himself by taking local medications like paracetamol in home.
Okay, acute abdomen is any abdominal illness that need emergent
Attention.
attention. Okay, that needs to be diagnosed and treated.
Yes.
Those are acute abdomen, and among them, acute appendicitis is also one. So, what are the things that will help you to make the diagnosis is acute appendicitis from history of present illness?
So, first of all, the patient presented with pain abdomen, fever, and vomiting. So these three classical presentation, these three are usually the classical presentation of acute appendicitis in the presenting
abdomen, fever, and vomiting, right?
Yes.
In abdomen, why will be pain abdomen in case of acute appendicitis?
The pain abdomen occurs because as there is ongoing ischemia in the abdomen, the parietal peritoneum gets irritated. So that's why there is pain abdomen in acute appendicitis.
Okay, one is because of the distension of the appendix itself.
Yes.
And ischemia of the tissue within, there will be pain. Another is localized
inflammation.
And inflammation. Okay. Why there is vomiting in acute appendicitis? You said these are the classical features.
Yes.
So why should there be vomiting in acute appendicitis?
So it is usually due to the pain that occurs in this disease. When the patient is suffering from pain, there sometimes occurs reflex spasm of the abdomen, a pylorospasm, and it results into vomiting. So.
Yes, it is because of the reflex. Any distension of the lumen of the GI tract, like if there is a distension in the appendix, there will be a reflex vomiting, and there are other reflex features. What are they? Because of the distension of the appendix or any tubular structures.
So one is the pain itself.
One is the pain itself. Another is bleeding.
Yes, sir.
Other.
Sometimes it may also result in diarrhea, sir.
Okay, that is reflex spasm, or if there is irritating pelvic appendix to the rectum, sigmoid, it might cause diarrhea. Another is anorexia. Okay, that is very important features of appendicitis. Okay, if patient is not hungry, it is very less likely to be acute appendicitis. So you have to keep in mind that there is reflex anorexia because of the distension of the appendix. So these are, so why there will be a fever?
So fever is usually due to inflammation of the appendix. Fever is a common systemic sign when there occurs inflammation in any part of the body.
So it is just because of the inflammation. Anywhere, if there is inflammation, there will be fever. So these are the main cardinal complaints of the patient. And next slide, Jawad. So in history of present illness, what are the things that you should ask to rule out the differential diagnosis? First, you have to tell me what are your differential diagnosis in this case with the chief complaint and history of present illness only. One is acute appendicitis. Other?
So one is acute appendicitis, and other differential diagnosis for this patient could be acute pancreatitis, acute cholecystitis, so, kidney stones, specifically urinary colic.
Yes. So as there is a pain in abdomen, especially in right iliac fossa, so there are other differential diagnoses like, and since he is female, 28 years old female.
Yes.
So it can be twisted ovarian cyst. Okay. It can be rupture, follicular cyst. Sorry, follicular, because she is in mid cycle, right?
Yes, sir.
She is in mid cycle. It will be rupture, follicular cyst. It can be just urinary tract infection. So what are the things that you should ask to rule out those differentials, and that you have to mention in HOPI? Okay, you have to rule out in HOPI.
So first of all, we have to ask about the pain itself. Okay? We commonly use a formula known as SOCR80. It is a very important, useful and easy way of knowing about the characters of the pain. First of all, we have to ask, where did the pain arise initially? Okay, generally, in a case of acute appendicitis, we see that initially the pain is around umbilical area, and later it migrates and get localized into the right iliac fossa. And this is characteristic of acute appendicitis, and it is not seen with any other type of acute abdomen, as far as I know, sir.
Okay. So what about mucous diverticulitis?
So, yes, sir.
Migration of the pain, as whatever you have said, can it be mucous diverticulitis? So how do you rule out?
So mucous diverticulitis, it usually presents in pediatric populations. So
Yes.
our patient is
There is the one point that is most of them will present in pediatric population, but it can also have periumbilical pain that will migrate it to right iliac fossa. Right.
yes,
So why does this common features occur in appendicitis and mucous diverticulitis? So what is the reason behind it?
so the reason behind this transfer or migration of pain from umbilical area to the right iliac fossa is usually due to the this due to the nerve involvement. Initially, the pain is umbilical because I actually forgot the name of that knob right now. Sir, could you help me here, please? I just could not. I'm not able to get that word out of my mouth. Exact word.
Most of the pain are visceral pain. In gut, they are visceral pain. Okay,
Yes, sir.
visceral pain are most of them are taken by sympathetics. Okay, and so visceral pain. What happened here is, do you know during the embryology?
Sir.
During the embryology, there is a development of the foregut, midgut, and hindgut, right?
Yes, sir.
So all the pain that occurs in foregut region, they are felt in epigastric region, whereas all the pain in midgut region, they are felt in
Periumbilical.
whereas the hindgut, they are felt in suprapubic or hypogastric region. Since both the mucous diverticulum as well as appendix, they are in midgut area, right? Midgut means after the second part of the duodenum to almost middle of the transverse colon. So all these are midgut. So they are initially filled in umbilical region. So what is the reason behind it migrating into the right iliac fossa?
So later on, it becomes more localized as the visceral peritoneum overlying the appendix is irritated. That's why the pain later on migrates towards the right iliac fossa.
Yes. And why mucous diverticulum pain is located in right iliac fossa? Why not in right upper quadrant? Sorry, left upper quadrant or any other reason?
So the reason behind this might be the fact that the location of the mucous diverticulum.
Yes, very good. Location of the mucous diverticulum. So where is it located?
So it is usually located 2 feet proximal to the ileocecal junction.
Yes. So most of the ileum, they are located in right lower quadrant, right?
Yes, sir.
Jejunum is located in left upper quadrant.
Yes, sir.
Right? If it would have been inflammation in the jejunum, it would have been the pain in left upper quadrant. So if there is inflammation in ileal region, then it is felt locally in right lower quadrant. Yes. So it is all because of the early there will be involvement of the visceral nerves that will that made us feel the pain in umbilicus. So when there is distension and inflammation in the right iliac fossa where there is appendix, there will be inflammation of parietal peritoneum, right? So when the parietal peritoneum is involved, it is somatic. And somatic answer. The somatic is more painful. So migration pain doesn't mean there is completely loss of pain of periumbilical region. There will still be pain. Okay, but somatic pain is so much severe that patient won't feel that of visceral pain. So he or she will complain more of the somatic pain that is in right iliac fossa.
Yes, sir.
In case of myocarditis, when it is located in right lower quadrant, most of the part of the ileum, it is felt in right lower quadrant. So with this history, the age is the one factor that will differentiate. It might more be appendicitis than mucous diverticulitis. Okay, sometimes it can be mucous diverticulitis when you do surgery, but the chances are here in this age.
Yes, sir.
So, ठीक छ और नेक्स्ट स्लाइड गर त okay, fever. What if this patient has fever before pain? Like he had fever 3 days back and then pain abdomen after just 2 days back.
So generally, the rule in appendicitis. It is said that the pain usually comes before any other sign, and if fever occurs before the pain, then we have to think of other etiologies, excluding acute appendicitis.
Yes, very good, right? Because pain should always be the first complaint of the patient rather than fever. If fever comes before pain, it is very less likely that it is acute appendicitis.
Yes.
If there is fever, then there are other infectious diseases that you have to keep on mind.
Yes.
Before pain abdomen, infectious disease, many like typhoid फिभरहरु हुन सक्छ any infectious disease gastroenteritis हुन सक्छ but in acute appendicitis there must be pain first that is followed by fever. Next slide gara. So you said that there is vomiting. What if there was increase in bowel movement?
So increase in bowel movement would have resulted in loose motion or diarrhea.
So it can be because of acute appendicitis itself or any other.
So could you please repeat the question? I could not understand what you.
Okay, you said upon further asking, she denies trauma to the abdomen. Any change in bowel movement?
So,
okay.
Yes.
Change in bowel movement means she has normal bowel movement.
Yes, sir.
So if she had increase in bowel movement in this patient.
So it may suggest that the appendix is due to the distension of appendix, it is irritating the intestine, and which has caused it.
It is because of inflammation. It is irritating the nearby rectum.
Yes.
Diarrhea, or it can be other differentials. Next slide, please. So why do you ask about cough, shortness of breath, chest pain, palpitation?
So it is usually as you yourself and our other teachers have taught us that systemic review in at the last part of history of presenting is very important.
Yes,
so that's
very important. But what is more important than that is to rule out the differential diagnosis first. So I'm not saying that you should not ask this. You should ask all this, but ruling out the differential diagnosis is more important. Means burning micturition should be kept prior to cough, shortness of breath. Okay, if there is burning micturition, the patient might have other differences like urinary tract infection, pyelonephritis, like that.
Okay, sir.
And alteration in bowel habit is more important than loss of consciousness.
Okay, sir.
Unless you think this is because of meningococcal enteritis. Right? They are more important. So during history of present illness, important things should come first. Sometimes what happens is even OBGYN history should come in the history of present illness itself. If you think that is the differential diagnosis. If it is ectopic, if you think it might be the ectopic rupture, then it should be in HOPI. हैन त्यतातिर जानुपर्छ यो खाली सिरियल भएपछि you have to ask everything. So she is currently on her mid cycle of her menses. So what could be the differential now here?
So generally during a woman's mid cycle, the ovarian follicle ruptures. So this might be the reason behind pain during mid cycle.
Yes, follicular rupture. Okay, next. So is there any role of sexual activeness for your management?
Yes, our patient is currently on her mid cycle, but if she hadn't been, then we would have to rule out ectopic pregnancy rupture. That's why I put about the sexual activity here.
Okay, next slide, please. Similar history in her sister. They should have at least said what they have done the surgery. Otherwise, no anything. Next. Do you think the patient's family history is gives some information regarding acute appendicitis? Is it related?
So I've read somewhere that if your siblings or any close family member, generally first degree relatives, have acute appendicitis in the past, then there might be chance that you also will suffer from acute appendicitis. Some studies have shown familial relations also.
Otherwise, no exact etiology is known for this disease. In
Yes.
economic history, you said Kuppuswamy grading, right?
Yes, sir.
Can you just tell us something regarding this grading? What are the parameters used in this grading and how is it done?
So it generally consists of a lot of parameters. So, okay,
Headings. There are many parameters. So
yes,
what
sir.
are the headings?
So in this, we have to ask about the educational status of the family head, how much he has or she has studied, about the earning, how much they earn, and so
Okay, there are mainly three parameters, right? What they seen, and specifically these three parameters are seen on head of the family, not all of family members. So one is education of the head of the family. According to the education, they have different scoring system. Right?
also,
Graduate, postgraduate, SLC, undergraduate. Okay, के छ अनि अर्को हेडिङ भनेको के छ occupation, what the head of the family does, होइन? That is another heading भनेको per capita income. So per capita income just does not tell the socio-economic status. There is education as well as occupation. We take involvement. So and they have grading according to that grade, and according to the different country ma different grading हुन्छ है. Per capita income in Nepal is different. हायर मिडललाई के हुन्छ त्यसलाई कति के हुन्छ इन्डियामा डिफरेन्ट हुन्छ अरू देशमा डिफरेन्ट हुन्छ है. So what is the importance of this socio-economic status?
So in the management of patients, socioeconomic status plays an important role, especially when it comes to developing countries like Nepal. Like if the patient can afford the treatment or not, is the family going to be supportive enough to cover all our expenses, including medications and possible operative interventions that we may have to perform in this patient.
Yes, and counseling of the patient पनि हैन depends upon how educated the patient is. यसमा यो कुपुस्वामी ग्रेडिङ युज गर्न पर्छ भन्ने छ हैन. How educated the patient is, what occupation or what is the profession of the patient, we can counsel accordingly. More educated people uses more kind of logic. They are rational, हैन.
Yes.
If they are less educated, they are more emotional. You know, so that's why you can talk rationally, logically to educated person, and we have to behave accordingly. That is for counseling. Next slide. Okay, this has no any drug and allergy history. Next, with your history, you said the differential diagnosis provisional is acute appendicitis. Differential are के भन्यो?
So differentials are acute pancreatitis, acute cholecystitis, and other might be ureteric colic, ruptured ectopic pregnancy, ruptured follicular cyst.
Okay, good. So, what do you expect from examination? Well, you have to make some kind of pictures. So examination गर्नुभन्दा अगाडि, what are the things that you should look to diagnose your provisional diagnosis and rule out the differential diagnosis? So just starting before the examination,
yes, sir.
You have to keep in your mind what are the things that you should look for to confirm your diagnosis that you have made in the history part and to rule out the differential diagnosis. Right? This
Yes,
we will talk. Now,
so okay, sir. So first of all, before doing any sort of examination, the consent of the patient is must.
Yes.
And if the patient is female, like in our case, then, and if the examining doctor is a male, then we need to have a female chaperone along with us. This is for medical legal importance.
Yes.
And since from our presenting complaint and for the part of our history, we have kept acute appendicitis as our provisional diagnosis, then we need to have some sort of overview in mind that we are going to find this findings in examination, so that after completing examination, we could say definitely that it is acute appendicitis from examination. So we need to have some knowledge or some knowledge about what are the examination findings that we can find in a case of acute appendicitis.
Look, continue the examination part, one other.
Okay, moving on to general examination. The patient is lying in supine position on the bed with her hand over her abdomen. She looks to be in discomfort. She is cooperative, conscious, and well oriented to time, place, and person. She is thin built with a body mass index of 21, and she has an IV cannula of 21 gauge on her right wrist. All the medical equipments that were present was a pulse oximeter that was connected to a cardiac monitor. Next, please. Moving on to her vitals. Firstly, pulse. Her pulse rate is 108 beats per minute. It is regular and normal in volume. It was taken in the right radial artery. Upon examination, no radial delay or no any radiofemoral delay was noticed, and the condition of arterial wall appeared normal. Moving on to her blood pressure is 120 by 80 millimeter of mercury on both arms, and it was taken in supine position. Our respiratory rate is 20 counts per minute. It is regular and thoraco-abdominal type. Upon taking her temperature on the right axilla, we found that her temperature was 101 degree Fahrenheit. Her oxygen saturation is 98% without any supplemental oxygen provided. So these are our vitals. Okay, moving on to head-to-toe examination. On examination, we noticed her tongue appears dry, but no any other abnormalities was detected while examining her head, neck, and chest. While seeing her abdomen, the examining doctor noticed that she had decreased movement with respiration on her right iliac fossa or right lower quadrant of the abdomen. Otherwise, her pelvis, limbs, back suggested no any abnormalities. No any signs of pallor, icterus, and cyanosis was seen. No any lymph nodes were palpable, and we did not notice any clubbing of her fingers. There is no any signs of edema present on this patient. Next, please. Okay, now comes the part of systemic examination. We have already talked about general appearance of the patient or vitals and head-to-toe examination. Now moving on to systemic examination of patient. Since our case, our provisional diagnosis and differential diagnosis are related to our abdomen, the abdomen of patient itself, so we start from abdominal examination. Okay, the font is quite not clear, okay, but it is abdominal examination. Firstly, we inspect the patient. On an inspection, we found that her abdomen is flat with umbilicus central and inverted. No any scar marks, venous prominence, or any discoloration was noted. No any visible pulsation and peristalsis movement were seen. All quadrants of her abdomen, except her right iliac fossa, are moving equally with respiration, meaning that our right iliac fossa is not moving equally as compared to remaining 3 quadrants of abdomen with respiration.
Why is that?
So it is due to the fact that we have presumed that she has acute appendicitis, and due to that reason,
You have to presume for that. There is decrease in movement of right lower quadrant during respiration, right?
Yes, sir.
So what does that mean?
So it means that there on the right iliac fossa there is occurring localized rigidity
of inflammatory sign going on, inflammation going on that area.
Yes.
So our body is trying to restrict the movement in that area. So it doesn't matter wherever the inflammation is, the respiratory movement will be decreased. If it is appendicitis, there will be decrease in respiratory movement of local peritoneum. In that side, if it is acute calculus cholecystitis, then there might be decrease in respiratory movement of right upper quadrant. And if it is sigmoid diverticulitis, colitis, there might be decrease in respiratory movement of left lower quadrant. So if there is local inflammations because of any cause, it will lead to decrease in the respiratory movement of that area. So you have to inspect very carefully during examination.
Yes, sir.
It doesn't matter whatever the diagnosis is, but there is decrease in respiratory movement. Means it might be gynecological cause, it can be surgical cause, it can be of any cause. This
Yeah.
thing that you have to notice.
Yes, sir. Okay, moving on. I would also like to add one more point, that since since the patient is experiencing pain, this uh, decrease in the moment of our abdominal wall on the right iliac fossa can also help to decrease our pain.
Yes.
On asking, okay, previous slide please. On asking the patient to show where the pain is present, she points with her index finger at her right iliac fossa. This is also known as pointing sign. Okay, it is a very important sign during the examination, or mainly during the inspection part of for abdominal examination. Okay, moving on to palpation. Firstly, we do superficial palpation. During superficial palpation, we notice that there is slight temperature rise on the right iliac fossa in comparison to other areas, but no any tenderness was felt on superficial palpation. Moving on to deep palpation. Palpation was started from left iliac fossa, and tenderness was elicited over right iliac fossa. Rebound tenderness was also present. No any other solid organs were palpable. So this is palpation part of the abdominal examination. Moving on to percussion, we note that throughout the abdomen, resonant sound was heard. And while percussing over the right iliac fossa, the patient complained of pain. That is, percussion tenderness was positive over right iliac fossa.
So what does that signify, percussive tenderness?
So percussion tenderness signifies that there is something pathological going, or something inflammatory process going underneath the area that we have just percussed.
That has made the parietal peritoneum inflamed.
Yes.
It is replacement for rebound tenderness. These days, rebound tenderness are not that popular. We have to avoid rebound tenderness as much as possible because it will cause more pain to the patient. So we replace it with the percussion tenderness. So it is almost equivalent to rebound tenderness. So rebound tenderness or percussion tenderness occur when there is inflamed parietal peritoneum. Right?
Yes.
Parietal peritoneum will get inflamed in peritonitis, either localized or generalized. So this means there is peritonitis that is localized. That is
Yes.
localized peritonitis. So this is important point, percussion tenderness. Next slide.
Okay, on auscultation, bowel sounds were heard, and it was about 3 to 4 per minute. Next slide. Okay, upon asking about the rectal examination, the patient denied this, and so rectal examination was not performed.
What do you expect on rectal examination in a patient with acute appendicitis or any acute abdomen?
So sometimes the rectal examination may elicit pain on the right iliac fossa.
It is hard. Sometimes the collection, because of any cause of acute abdomen, might be felt in rectovesical or rectouterine pause during examination. Right? The collection there might be inflammation in this area that can be felt, and it might cause tenderness in that area. Right? If there is no collection, then it is less likely to be significant for rectal examination. Is it?
Yes, sir.
Aru?
The rest of the examination, including central nervous system examination, respiratory examination, and cardiovascular examination, was unremarkable.
So they might be remarkable in what type of condition secondary to acute appendicitis?
So, if there has occurred perforation of the acutely inflamed abdomen, then we might see other features as well.
Yes. So if there is complicated appendicitis, means if there is appendicular abscesses, if there is perforation of the appendix, there is now systemic features leading to systemic signs and slowly affecting the other organs.
Yes,
More specifically called sepsis, features of sepsis. All these systems might be involved, right? So they are all normal means it has not yet started. Next.
next. Okay, so as to summarize our history and examination, Mrs. Thapa, a 28-year-old lady, presented to the emergency department with complaint of right lower abdominal pain, which was initially periumbilical, later migrated to right iliac fossa, fever of 101 degree Fahrenheit, and multiple episodes of vomiting. Her systemic review from history does not reveal any abnormalities. Other components of the histories are unremarkable, except the fact that her sister had similar complaints in the past, for which her sister underwent operative management. On examination, she appears distressed, tachycardic with a pulse rate of 108, normotensive with a BP of blood pressure of 120 by 80 mm of Hg, breathing normally, and her oxygen saturation is 98% without any supplemental oxygen. Her tongue appears to be dry, and we've noticed decreased movement with respiration on the right iliac fossa.
Means it is better to just say the significant findings. Normal SpO2 भनिराख्नु पर्दैन. The significant that is important for the diagnosis and management. भनेपछि के छ significant त्यो मात्रै भन्दा it is more helpful, right?
Yes.
त्यो सबै भन्यो भने it will be again same history.
Her tongue appears to be dry, and we've noticed decreased movement with respiration on her right iliac fossa. Next slide. Upon inspection, her right iliac fossa shows upon inspection during the per abdominal examination, her right iliac fossa showed decreased movement with respiration. Upon palpation, we noticed a raised temperature on the right iliac fossa with tenderness and rebound tenderness present. On percussion, tenderness was also elicited over the right iliac fossa. Her bowel sounds were heard during auscultation of the abdomen and said denied for rectal examination. Review of other systems revealed no abnormalities.
So, already. So, Aaryan, with all this history and physical examination, I think you have already consolidated your diagnosis as acute appendicitis.
Yes.
Right? And what about other differential diagnosis? How do you try to rule out the differential diagnosis like pelvic inflammatory disease? It can be PID.
Yes, sir.
So, have you asked some questions regarding this?
So first of all, we have to ask about her menstrual cycle. How the cycle is it regular? It is irregular? How is the flow during her cycle?
Okay.
And is she experiencing any undue discomfort, undue dysmenorrhea during her cycles or not?
Okay. Anything other than that?
So systemic signs are more important in pelvic inflammatory diseases also.
What vaginal discharge? Okay.
Yes, yes, sir.
You have to ask, because so what are other differential diagnoses then, other than PID? Or के हुन सक्छ?
So other differential diagnosis could be acute pancreatitis.
So what happens in acute pancreatitis?
So in acute pancreatitis, the pain is usually on the epigastric area,
Okay.
The vomiting and fever are also more pronounced than in acute appendicitis.
Here, one is site of the pain is important. Right?
Yes,
Another
yes.
is severity is very important. If pain is very severe, it is very less likely to be acute appendicitis. Right? त्यो पनि ध्यानमा राख्नु. If pain is very serious, पेसेन्टले खप्नै सकेको छैन, it is more likely to be acute pancreatitis. It can be ureteric colic, it can be anything, but it is less likely to be acute appendicitis. So severity there is very important. So pancreatitis na pani, it will be more severe. There will be radiation of the pain to the back. Okay, tell me the differences between radiation of the pain, migration of the pain, and what was other referred pain. के difference छ यो तीनटामा?
Sir, first of all, about the migration of the pain.
Okay.
Suppose example, if the pain was initially peri-umbilical and later it went, the pain is more on the right iliac fossa. And if the initial pain is absent, then it is called migration of the pain. The pain was initially present on one part of the body. Later, it migrated to a second part, but the first pain is not now, is absent right now.
So there will be pain initially at one side, then it will shift it to the other side. So there is no common sharing of any knobs or anything like that. Okay, there is totally change of the site of the inflammation or pain in migration of the pain. In referred pain,
So in referred pain, it is usually associated with common dermatome, involvement of common dermatomes.
example, give us the example.
So for example, the pain of acute cholecystitis could also present as referred pain to the shoulder, specifically right shoulder.
Why?
So because the nerve supply is such that our phrenic nerve supplies the area of that area of diaphragm and also that area of shoulder.
So it's
So
the same knob supply.
yes,
That is called referred pain. Okay, if there is some collection in right upper quadrant or right hypochondrial region, then there might be pain in the right upper shoulder. Likewise, in case of cardiac pain, there might be pain referred to left shoulders. So they are because of the same shared knobs. What is radiation of the pain knob?
so radiation of the pain is the pain was initially on one side, then on the second side the pain is also felt, but the primary pain is also present. It is like the pain is radiating from one point to other. It is also present on the initial side.
Initial side, and it is again they share the same knobs, and the pain rages and it ends as a matter of seconds. It rages and it goes. Not like referred pain, it keeps on staying.
Yes, sir.
Radiation of the pain के हुन्छ धडाक्क आउँछ जान्छ. Same knob ending बाट है. Good. So अरु differential diagnosis, why not this is duodenal ulcer perforation.
So duodenal ulcer perforation can also be kept as a differential diagnosis of this case. But during taking the history of pain abdomen, the patient has denied that the pain has any relation to the food intake. So one is that. Another one is that she denies any such previous history of similar pain like in duodenal ulcer or in duodenal ulcer perforation. We usually get an history of acid peptic disease prior.
Okay. Other.
So if
sudden onset of pain, right?
yes,
That is significant in duodenal ulcer perforation or peptic gastric perforation. So sometimes you might say the exact time of the pain. Doctor, I had a sudden onset of pain in my abdomen at 6:45 p.m. or whatever. So the exact is there. Sudden onset is duodenal ulcer perforation. So she had sudden onset of pain. So why can't it be? One is history, other.
So usually duodenal ulcer perforation, it presents as an epigastric pain.
Epigastric pain, yes, good. Aru?
and later it can become generalized pain, sir.
There is one condition called Valentino sign, I think. What is it?
Uh, so, so I don't think I'm able to recall this one. I've heard about it quite few times, but
It means okay, this is a famous Hollywood actor in the US. What happened was he had features of acute appendicitis, like you have presented here, and surgeons thought it was acute appendicitis. They operated, and after surgery, the patient, this Valentino, the famous Hollywood actor, Italian actor, he died 2 to 3 days after surgery, right? And on autopsy, they found it was not acute appendicitis. It was duodenal ulcer perforation.
such a tragedy, sir.
So tragedy. So how to prevent this type of incidents again? To prevent that, you have to know what happened in that patient.
Yes, sir.
So what happened is during the duodenal ulcer or peptic ulcer perforation, there is sudden onset of pain, and there is uh, expulsion of the content of the stomach or duodenum in the abdomen, right?
Yes,
So
sir.
this time is called chemical peritonitis, and after a few hours, it goes to the time of neutralization where patient get relieved, and not just the patient get relieved at the time, but the content of the stomach or duodenum that goes to the right iliac fossa through right paracolic gutter. Now that content will start inflammation in parietal peritoneum, not appendix, parietal peritoneum. So once there is inflammation on the parietal peritoneum, then there is the tenderness and rebound tenderness both in right iliac fossa. So patient present to you with the complaint of pain in epigastric region at the sometimes after at first time there will be pain in epigastric region that has been migrated to the right iliac fossa. So patient gives somewhat features of acute appendicitis. There is migration of the pain, and they thought it was acute appendicitis. So just to avoid this, you have to always keep on mind while diagnosing any acute abdomen. All the acute abdomen should be your differential diagnosis. Okay, you should not be that confident.
Okay, sir.
त्यसपछि अरू differential diagnosis, why not? It is acute cholecystitis.
So, the pain of acute cholecystitis is usually located on the right upper quadrant, mainly right hypochondriac region.
Okay, I think we have not much time left. So, at the end, now you have made some provisional diagnosis and differential diagnosis. Now, tell me, uh, how do you counsel the patient? This patient.
So, regarding the counseling part, after taking thorough history and doing a comprehensive examination, we share to the patient that we think that her pain abdomen might be due to pathology in her appendix, namely acute appendicitis. We counsel her regarding how we are going to confirm that it is acute appendicitis, and we also counsel her and her husband that she might have to undergo operative intervention in order to treat this condition.
Okay, very good. And another thing is that I have already told you that don't be very much confident about your diagnosis, because that happens to in our field. Everything you are gray medicos, right? Gray means there is nothing like this is white and this is black in medical field. There are very lot of areas of grays where we use our best logic to make a diagnosis or manage. So don't say that this is acute appendicitis, I have to do surgery. Just say like this: with your history and examination finding, it looks like acute appendicitis, but it can be sometimes other differential diagnosis. Infection of the urine, it can be acute pancreatitis, it can be cholecystitis, it can be duodenal ulcer perforation, it can be salpingitis, uveitis, Meckel's diverticulitis, keep say everything. but more likely it can be appendicitis. To confirm our diagnosis, I will do some tests like ultrasound, whatever, blood count and all those things. Once the report are back, then I am able to tell you what is wrong with you. जहिले सेफ साइडमा बसेर खेल्नुपर्छ है. सुरुमा हिस्ट्री एक्जामिनेसनबाट दिस इज योर डायग्नोसिस नभन्ने. सो हाउ टु कन्फर्म दिस डायग्नोसिस एन्ड रुल आउट अदर डायग्नोसिस?
So we have to send quite a few basic investigations and some investigations that will help to aid us whether it is acute appendicitis or not. Usually, if we are in a high research setting and the patient is affording, the confirmatory diagnosis of acute appendicitis can be obtained by doing a CT scan of the abdomen. But usually in our setting, an ultrasound is preferred as it is cheap and an easy way of diagnosing abdominal pathologies.
One is ultrasound. It can tell us what might be the cause. Other.
So we can also do abdominal X-rays to rule out other differential diagnosis like as you said earlier, duodenal ulcer perforation.
Yes. Other investigations.
So other investigations that we can send are hematological investigations like complete blood count, or renal function test, and urine routine microscopy to rule out any urinary tract infection is present or not.
Okay, generally, what happens is in acute abdomen, it is better to rule out some other common acute abdomen. Okay, like you said, X-ray, chest, erect, just to see whether there is gas under right diaphragm or not. It is better. Other ultrasound will tell if there is appendix or if there is stone or inflamed gallbladder or not. So we don't have to add any more investigations. Another that I prefer is amylase or lipase. If it is clear-cut appendicitis, then it might not be necessary. But sometimes, if you think it is hollow viscous perforations or duodenal ulcer perforation, cholecystitis, then that should be added as well, right? And other acute abdomen that you have to rule out is intestinal obstruction. For that, you have to do X-ray. So you have done investigation, ultrasound, blood count. So what do you expect in those investigations in acute appendicitis?
Sir, among the hematological investigations, in complete blood count, we usually see the increase in total count of the patient with predominantly neutrophils.
Yes. And there will be features of appendicitis in ultrasound. So how would you manage this case? Once it is diagnosed as acute appendicitis and you have ruled out other acute abdomen, you did chest X-ray, other investigation, you rule out. So now how would you manage?
So once we have confirmed that this is a case of acute appendicitis, generally the most accepted management of acute appendicitis is operative management. We have to counsel the patient regarding the complications. We have to counsel the patient regarding what is our management plan, how we are going to proceed further, and what happens if we do not operate her right now.
Yes. First, you have to counsel, okay, what is the natural course of the appendicitis if nothing is done, and what is the first treatment of choice, second, third, and surgery. So what do you expect in surgery? So
the intraoperative findings, we may see an inflamed appendix with some adhesions around it.
Sometimes difficult position might be difficult to locate. That is the very common thing for the beginners or residents. Okay. So is there any clinical clue where the appendix might be during your examination? Examination गर्दाखेरि कुनै clinical clue हुन्छ?
Yes, so there are few examination signs that may help us to locate the appendix. One of them is Cope-Psoas test.
Was test.
Another is obturator signs.
What does it signify? Cope-Psoas test.
So Cope-Psoas test signifies that the appendix may be lying on the pelvic region.
सुवास पेल्भिसमा हुन्छ
बिर्से जस्तो लाग्यो, अलिक धेरै नै भएछ रिभिजन नगरी
हैन रेट्रोसिकल एपेन्डिक्स है
ओके सर
retrosical appendix posterior psoas माथि बस्छ that's why there will be positive psoas sign. So these are the early clinical signs that might help you to guide for surgery भनेको के अर्को if the appendix is pelvic then the obturator sign might be positive that you have to so theory knowledge is important that's why because it's not that ultrasound will tell you appendix and you go and directly operate. So if you do all those examinations very nicely then it will help you to do surgery. So during surgery, what are the things that you should remove?
So during surgeries, we have to remove the inflamed appendix up to the base, up to the base of the appendix.
Okay, what is the artery that you ligate?
So we ligate the appendicular artery, that is the main blood supply of the appendix.
Okay, very good. So, what are the complications of appendectomy surgery?
So, as with any surgery, there may be chance of bleeding, injury to the nearby important structures, and specifically to the surgery of acute abdomen, the patient may later face complications like formation of a fecal fistula.
So common are like surgical site infection and all those things, artery injuries. Significant is fecal fistula, right?
Yes.
That we have to manage. If appendicitis is not treated, what could be the consequences?
So if the patient opts for non-surgical management, or if there is delay in the treatment of acute appendicitis surgically, then it may resolve on its own. One is that. Second is that it may form appendicular abscess. Third is it may perforate, leading to perforation peritonitis. And the fourth is it may become appendicular mass.
That is it. So now, how do you treat appendicular abscess? How does appendicitis?
Once again.
Treatment of appendicular abscess.
So treatment of appendicular abscess is generally conservative. The regimen used for the treatment of
appendicular.
Sir?
It is not conservative.
Okay. I was telling about. I'm sorry. I was telling about the appendicular mass. Any abscess in the body needs to be drained, sir.
Okay. So how is it drained? That was my question actually. We have to drain it retroperitoneally without entering the peritoneum.
Yes,
Once the abscess is drained, we do appendectomy only after 6 weeks. Right?
Yes.
But so is there any queries? Time bio. So there are a lot to discuss in acute appendicitis. So it is a very big thing.
So there is one question, sir.
Okay.
The question is, what is the significance of dry tongue?
It is dehydration. Okay, let's say in any case of acute abdomen, there is very high chances of dehydration or fluid loss. Dry tongue is dehydration, and we have to resuscitate the patient. And it is earlier sign of sepsis as well. If there is dehydration, there is a decrease in urine output leading to AKI. So that had to be catched as soon as possible. And they have to rehydrate it before doing surgery or doing any management. So dry tongue is very important, right?
Also, the patient like multiple episodes of vomiting when and you, as you also said that due to appendicitis, there may be anorexia, the patient is not drinking or feeding well, so it might lead to dehydration.
Okay, thank you, sir. The question was from Srina and Pusparaj.
Okay.
If any more questions are there, then you can mention in the chat box.
So management of appendix is not just surgery. Okay, first you have to resuscitate the patient, see whether the patient's vitals is normal or not, whether they are dehydrated or not, resuscitate them with fluid, and after some investigation, see the electrolytes. Okay, and manage that. After managing all those things, then only we can perform surgery. Okay. Any other questions?
Sir, good evening, sir. Sanjana. Okay, मेरो क्वेसन चाहिँ होइन स्टुडेन्टहरू मोस्टली कन्फ्युज भइरहन्छ यसमा चाहिँ, त्यही भएर ट्रायड अफ एपेन्डिसाइटिस भनेर क्वेसन्सहरू सोधिन्छ होइन एक्जाममा, अनि सम बुक्स ह्याभ anorexia in the triad and some books have different, they don't include the anorexia in the triad. So actually हामीले एन्सर भन्दाखेरि चाहिँ के भन्नुपर्ने हुन्छ, यो धेरैजनालाई कन्फ्युजन हुन्छ, मलाई नि फाइनलमा कन्फ्युजन भइरहन्छ त्यसमा चाहिँ।
यस्तो हुन्छ, पेन कम्प्लेक्स हैन,
हजुर,
not like this is this and that is that. That's why it is great. Anorexia, vomiting, they are caused by the same thing. Of the appendix itself, you know. Vomiting, now it doesn't matter. If the patient is not anorexic, then it is less likely to be appendicitis. So I think anorexia is more important point than vomiting itself.
ओके सर, सो त्यही उसमा हाम्रो बेलियलमा पनि एनोरेक्सिया नै छ, त्यो एनोरेक्सिया नै पढेको थियौँ हामीले चाहिँ, त्यही भएर
Anorexia is a very cardinal sign of appendicitis. मैले भने नि, if patient is hungry, it is very less likely to be appendicitis.
Yes sir.
नभए पनि हुन्छ बरु, त्यो नभए पनि हुन्छ. Patient that right iliac fossa patient is anorexic.
Yes sir.
Likely to be appendicitis.
Yes, thank you sir.
Any other questions?
सबैजनाले बुझे जस्तो छ।
एक क्वेशन छ भने ह्यान्ड रेज गर्नु होला, म अनम्युट गरिदिन्छु।
पढिरहेको छु हैन, रामबहादुर खड्का from CMS. From the time of pain, how long before complication happen, surgery should be done? Okay, this is very good questions, and it is not like that. This is again gray area when complication happen and when complication does not happen. But specifically, what type of patient will have early complications, like children, okay, old people, comorbid people, they are likely to have complication at early stage. In children, they don't have fully matured omentum to cover the appendix and form a lump. So chances of perforation is very high in children. So it is better to operate as early as possible in case of children, as well as in older people where omentum is atrophied. So it is better to do surgery 24 hours after the onset of the pain. After that, it keeps on getting complicated. Our body will try to help our body to go into sepsis by localizing it within a lump. If that fails, then it will perforate. It might be, there might be abscess. So early the better. There are certain parameters that will help us to say this is a complicated appendicitis and this is not. One is the duration of the pain itself. Longer the duration, higher the chances of complication. Another is blood count, WBC count. I have one article published in Journal of Nepal Medical Associations on a topic that the clue to find whether this appendix is complicated or not. Okay, you can, especially in pediatric population. And what I have concluded is just two things that has helped us to find it is complicated or not. One is duration, another is WBC count. Topic, but
sir,
Azul.
Sir, what might